So we'll be speaking today about non-opioid clinical pharmacology and chronic pain management. Again, I'm David Tauben, the chief of the pain division, and in the departments of anesthesia and pain medicine and general internal medicine. Disclosures are that many of the drugs I'll be speaking about are off-label for pain, but much of what we do in pain has not been adequately studied yet. So we're basing this on clinical consensus data and clinical experience of our faculty as well. Objectives will be, number one, to describe why chronic pain medication should not be opioid monotherapy. We'll discuss also the clinical value and potential side effects of NSAIDs, anti-inflammatories, tricyclic antidepressant drugs, other categories of antidepressant drugs, and anti-epileptic drugs. And finally, and most importantly, we'll talk about the role and value of non-drug options for management of chronic pain. Of note, by way of opening here, this is the Centers for Disease Control guideline recommendation number 1. So this is considered to be of such great importance that it is number 1, and certainly the recommendation as it reads, non-pharmacological therapy and non-opioid pharmacological therapy are preferred for chronic pain. You see on your slide there a screenshot of the guideline, worth reading. Easy, Google or Bing it, first hit for that, and the guidelines are detailed, not just the recommendation, but strong supporting evidence that has led to that. Preceding the CDC and certainly long preceding here in Washington State, we've been struggling to find satisfactory evidence to support the effectiveness, and indeed, and it's published in Annals of Internal Medicine about a year ago now, report said evidence is insufficient to determine the effectiveness of long-term opioid therapy for improving chronic pain and function, and evidence supports a dose-dependent risk for serious harms. And that's what drove the guidelines. That's what's been driving our work here for the WAMI Pacific Northwest region, and what we're hoping to talk about today. So to get started, let's talk about non-drugs first. This is courtesy of Deb Gordon, doctorate and nurse at Harborview, who has put together the techniques of non-drug analgesia, including empathic listening, relaxation techniques, imagery, distraction, motivational coaching, heat, cold, muscle relaxation, exercise and mobilization, and patient education. Cognitive behavioral therapy and coaching interventions we've discussed as well, and other of our sessions go into these in more detail, but they decrease anxiety, lessen pain intensity, reduce opioid utilization, improve treatment satisfaction, increase treatment adherence, reduces cardiovascular and neurological stress, improves respiratory function, and accelerates recovery. All powerful entities, and in fact we now know more effective than the drugs we use are the non-drug therapies, and this audience is well informed on that. Here is a comparing effectiveness summary I put together for you, demonstrating that the best we get with our drugs, even our non-opioids, is no more than 30% on average reduction in pain, to the point where there's 50% relief. We can see acupuncture gives us 10 or more % benefit, but notice cognitive behavioral therapy and mindfulness, over 40%, as high as 50% reduction in pain measures and improvement in quality of life and function. And as we know, no reported overdoses on mindfulness yet reported. Please send me open access to my email, any case, because we need to learn about that. But at this point, the safety factors and the effectiveness support non-drug therapy. Sleep is the most important problem in our patients with chronic pain, certainly acute pain, but chronic pain especially. Benzodiazepines, this is again in the CDC guideline recommendations, are not recommended to be co-prescribed with opioids. Many reasons not to do that, including dying in your sleep of an accidental overdose, since they stop respiratory drive. First and most important, your patient needs to sleep more than 6 hours, and just improved sleep will improve pain intensity levels by 40%, as effective, more effective than any of our drugs, and certainly more effective than opioids. As many of you know, tricyclic antidepressant category drugs are our favorites here. One of my favorites because it improves not only sleep and of course mood as an antidepressant, but has powerful analgesic, pain relieving effects. It improves quality of sleep and there's no known dependency. Melatonin over the counter, also useful. Biggest sticky point is that it's 3 to 4 hours before the patient's ready to sleep. This is not well known and is a great pearl when you recommend melatonin, 5 to 10 milligrams. Sets the brain up to get ready for sleep. Acetaminophen, effective to a moderate degree. Be careful of combining this with other over-the-counter products that the patient may be taking, and remember that brand name drugs like Percocet and Vicodin include acetaminophen, and your total acetaminophen dose ought to be less than 4 grams a day. So count the milligrams. And for age over 60 or anyone using alcohol, the dose limit is recommended at 2 grams or less. So it's pretty easy to get to that dose, and you need to be cautious. Anti-inflammatories, excellent drugs for nociceptive pain that's associated with inflammation or early tissue trauma. Not terribly effective for chronic pain. Very high incidence of adverse effects, including raising blood pressure, interference with all your blood pressure drugs, and causing renal injury, as well as gastrointestinal bleeding. One needs to monitor these drugs carefully, and when there is nociception, i.e. active tissue injury and inflammation that's wound up the sensitivity of the nociceptors, they are relevant, but when nociception is not present, these drugs are not recommended, certainly in chronic pain. The famous gate theory of pain, we think we now know where the gate is. The gate appears to be in the brainstem and the spinal cord, and norepinephrine is the magic sauce that provides the facilitation of closing of the gate. These facilitate the descending inhibitory pathways. You see in the graphic there that the periaqueductal gray, where migraines generate, the rostroventral medulla, a powerhouse of norepinephrine in the brain, and the spinal cord are extremely sensitive to drugs that have norepinephrine reuptake inhibition, and they reduce the ability of the pain system to send the message upstream and therefore reduce the pain intensity. So we're not giving these drugs because patients are depressed, though they may be. Pain is a depressing, terrifically life-changing event, not for the good, but because they're analgesics, and they are very effective if they have sedative properties to manage the sleep disorder as well. I'm calling out the central sensitization sequence here because the drugs that we use for management of all of these syndromes, initially described for fibromyalgia, but also for irritable bowel syndrome, tension headaches, temporomandibular disorder, myofascial pain, pelvic pain, and bladder pain syndromes. These all represent features of the central sensitization pinwheel of disorders, and these are treated not with opioids, which make all of these worse, but with drugs that reduce sensitization. If we're using drugs and other methods of reducing sensitization, that includes physical exercise, mindfulness, and cognitive behavioral therapy. Again, all safer and more effective. So these drug syndromes, when they present, starting with non-drug therapies, we hear much of those in our other sessions, but considering that we're talking about the drugs that we use as well, consider these as first-line therapy for unexplained bowel pain, pelvic pain, bladder pain, jaw pain, headache pain, and muscle pain syndromes. So effectiveness for tricyclic antidepressant drugs, there's a very robust literature that supports its role in postherpetic neuralgia, diabetic peripheral neuropathy, facial pain syndromes, and very impressively in fibromyalgia, where the numbers needed to treat, that's the number of patients that need to be exposed to this drug to get a reduction of pain by 50%, 1 out of 1.7. That's a very high likelihood that you're going to get good results. Similarly, for diabetic peripheral neuropathy, about the same quality data. Evidence also less robust for pelvic pain syndromes, although they are now listed as either the number 1 or number 2 drug for chronic pelvic pain. Limited evidence in mononeuropathies, but if sleep's disturbed, people are distressed, moving forward with these drugs early makes sense as well. We use the SNRIs, the serotonin norepinephrine reuptake inhibitors as well, well advertised and also quite expensive. The brand name, the generic being duloxetine for diabetic peripheral neuropathy, also for fibromyalgia, and other two generics I've given you, venlafaxine and milnacipran, have almost as good evidence-based support as the tricyclics, and they are a bit easier to dispense for your patient because of fewer side effects. But the use of SSRIs are not effective. So you need that N, that norepinephrine, that shuts the gate to be able to demonstrate significant effectiveness in both fibromyalgia and diabetic neuropathy. Side effects, quick flyby on side effects because they are worrisome with all drugs. In cardiac disease and arrhythmic states, one has to be very cautious. They cause dry mouth, urinary retention, constipation. We like the sleep benefits, but they could be too sedating, so we have to be cautious. People could be lightheaded. Other side effects, including precipitation of mania and suicidality in patients, need to be attended to, and hence they're tricky but effective, and one should think of these early in management of chronic pain syndromes. Don't forget that cyclobenzapine or Flexeril is a tricyclic. It's just one hydrogen atom away from amitriptyline. Don't ever use carosobrodol or Soma. It metabolizes to a dangerous drug that's been withdrawn from the market. It's astonishing it's still on the market. If there's spasticity present, baclofen, GABA B agonist, or tizanidine, an adrenergic agonist, also play a role at different sites. That's for spasticity, but muscle spasm is treated as a central pain syndrome for most cases, and you're going to want to use drugs that are effective. The most popular drugs now, for good reasons, because they have a low side effect profile of great worry, are the gabapentinoids. This is gabapentin and pregabalin, or Lyrica by brand name. The numbers needed to treat data are not as favorable as we see for the tricyclics, but the side effect profile is known by the patient. They'll gain weight, get swollen, have troubles with balance. These are side effects that the patient will report to you, and you don't have to dive deep because they will tell you they're having these side effects. Again, reasonable drugs stacked at night to help sleep, quite effective in management, again, of diabetic peripheral neuropathy, fibromyalgia, and all the central sensitization states I've described. You all are familiar with carbamazepine, Tegretol from decades ago. It's still an effective drug. It works at a different site than the gabapentinoids. They appear to be working at the calcium, the sodium channel antiepileptics listed here, carbamazepine for trigeminal neuralgia, oxcarbazepine is evidence-based support for multiple sclerosis-related pain, and lamotrigine for both trigeminal neuralgia and HIV-associated peripheral neuropathy, as well as diabetic peripheral neuropathy, also effective, working by a separate mechanism. Their problem is they have a nasty list of side effects that you do have to monitor. Think of sodium channel, think of abnormalities of sodium excretion, hence SIADH, where your patient can become dangerously low in their sodium levels as a result. You can read the list as well, and I've linked them to the drugs in the slide. This would be for your own reference at a later date, but rashes, blood count abnormalities, abnormalities of bicarbonate excretion, so patients can develop an acidosis, kidney stones, and glaucoma. So these are not first line generally. One would want to go either gabapentinoid or an antidepressant category with norepinephrine as first line therapies. These drugs are also used for headache disorders, as mentioned, for chronic pelvic pain and chronic abdominal pain syndromes, and more commonly and an increasingly robust evidence-based support for perioperative hyperalgesia prevention. So post-thoracotomy procedures, we know that exposure to gabapentinoids early and pre-surgery will lead to a reduction in the amount of postoperative pain. So these are becoming better studied, and as our evidence-based support generates, we'll become more knowledgeable and expert at what dose, how often, and how long we continue with these. And don't forget the products that patients can apply directly on their skin. Capsaicin interferes with the TRPV1 as an agonist, and therefore it interferes with the pain sensation from the periphery. Menthol, we don't know quite how it works, but it is effective. Be careful with menthol because the urine drug screen may come up positive erroneously for methamphetamine. So that menthol group and the methyl group can cross-link, and as we discussed in other sessions, about urine drug toxicology, this would give a false positive. Is effective in pain. Again, methamphetamine, yes, but not benthol for pain. No reported overdoses. We're still looking for one. Magnesium, effective. It has a number of interesting properties. This is just magnesium tablets you get at the health food store. NMDA antagonist, calcium channel blocker, inhibits catechol release from peripheral nerve endings, and it improves the constipation that many of our patients have from their other drugs that they're using. So quick summary. Non-opioid effectiveness is at least as good, if not better, for opioids than for opiates for chronic non-cancer pain, and generally with much lower risk. Tricyclics appear to be the most effective for neuropathic pain, but the gabapentinoids also are useful. Best evidence for non-opioid effectiveness is fibromyalgia, diabetic peripheral neuropathy, and headache. We know that opioids in fibromyalgia, opiates in headache, and opiates in non-specific back pain worsen these conditions. So these are alternatives to opiates that don't lead patients to get worse, but they actually improve. There's limited randomized controlled trials for the old traditional anti-epileptic drugs, and there's increasing evidence for reduction of hyperalgesia of the anticonvulsant drugs, but side effects are common, and you're still not off the hook being a prescriber of drugs, knowing what they are and how to monitor.